no further ado, Kate.
Thanks, Steph. So we'll be starting off with talking about the Graston technique, and then we'll go into the dry needling with Becca. So as physical therapists, we're always trying to expand kind of our toolbox, the things that we can do for our patients. So we've decided to take some of our soft tissue techniques and go another step and see what we can do to not only save our hands, but help our patients a little bit better. So one of those techniques we use is the Graston technique. So the Graston technique is kind of lumped under a group of instrument-assisted soft tissue mobilization. So you may see this term out there. There are some other systems that are used in PT clinics, chiropractor clinics, or even in an athletic training room. And really all it is the use of instruments to perform our soft tissue mobilization. So to perform things that we would normally use soft tissue massage for example, with our hands, we can now use instruments to do so. They come in a variety of different materials. They might be plastic, ceramic. I've actually talked to PTs who use something that's basically like a rock. We didn't go quite that far. We actually use stainless steel instruments, and we'll go into that a little bit more. So the nice thing about the instrument-assisted soft tissue mobilization, number one, is it actually really increases the sensitivity of our hands, because our hands are fairly broad, and as you'll see, the tools have kind of a small treatment edge to them. So even with a small treatment edge, we can keep everything comfortable, but it does give us a little bit more information. We can feel where there are more little bumps and little areas of the tissue that just aren't quite right, because a normal muscle, for example, if it's relaxed and it's healthy, it should be soft and supple, even a nice strong muscle. So that's what we're looking for with the instruments as well. Ergonomically, it's great for us as physical therapists. It really saves our hands. We do a lot of work with our hands during the day, and if I am performing more of my soft tissue mobilization with Graston tools, it allows me to use my hands for other things like joint manipulation. So the Graston technique in particular, it's actually an evidence-based intervention. We do have some evidence to support its use in physical therapy. It uses stainless steel instruments, so no rocks for us and no plastic. And it helps us better detect the soft tissue dysfunction as well. Like I said before, it's because it sensitizes our hands a little bit more. The Graston technique is a little bit unique compared to some of the other IASTM tools in that it uses a combination of training and the instruments for the techniques. You can get different tools just out on the marketplace. I can go on Amazon and get some tools, but the training is a big part of it. These are the typical Graston instruments that are used. We typically use just 3 of the instruments currently. They all have either a single or a double beveled edge. And what the beveled edge does is it allows us to get into the tissue a little bit more easily, but it's still quite comfortable. We don't have to put a lot of pressure on the patient's leg or their arm or into the soft tissue to get the same effect that we would get with just using our hands. If someone's a little bit more sensitive, we might use something that has a double beveled edge, and that has a nice rounded texture to it. It's really comfortable. So if we were to perform a Graston treatment, or we'll sometimes just call it GT for short, we'll usually do some kind of warm-up. So we might have the person get on the bike for a couple of minutes first, or do some exercises just to loosen up the tissue. They might be on a foam roller for a few minutes to get things moving, or maybe something like a moist hot pack or ultrasound, just to kind of get the tissue warmed up. Then we'll use our technique, which we'll go over in a few minutes, and then we'll follow that up with stretching and exercise. One of the things that's really important is this isn't a technique that should be used in isolation. It's something that's just another component of our physical therapy treatment. And the GT instruments have actually been compared to a stethoscope. It just amplifies the noise that's coming out of the tissue, similar to your physician trying to listen to your heartbeat. So what we do with the instruments is we actually just glide them up and down the tissue. We don't stay in one particular pattern of movement the whole time. We'll change the pattern as we're moving around, because I may move up somebody's arm and it'll feel completely different than me moving down someone's arm with the same instrument with the same length of stroke, because the tissue is different in all of those different areas just with the change in direction. Once we identify those areas that maybe feel a little crunchy to us, or the patient says, oh, that feels a little bit lumpy, or oh, it just feels like it's grinding in there, we can kind of work in that little area to kind of loosen it up, and then it'll smooth. Basically, you feel like it just smooths out. It's almost like you're flattening out the tissue. As I said before, there is some research to support GT. If you look at this chart here, so up in level A, that's our really strong evidence in the physical therapy and the medical literature, and F is kind of our lower level of evidence. Now all of these, even though F doesn't sound quite as good as A, there is support for things that are down in the level F, and that would be an expert opinion. So most of the GT literature falls within the C and E range, which is usually categorized as fairly weak evidence, or some theoretical evidence. So it might be a study that was performed on an animal model, for example. But there is still evidence out there. And the other thing is we just have our own experience with the techniques that tell us whether it works for someone or not. Personally, for me, as much as I love the medical literature, if you come to see me and we perform GT or we do a certain exercise and you feel better afterward, to me that probably worked okay. So you'll see the Graston technique mentioned even out in kind of pop culture and the sports world. Michael Phelps, back from the Olympics, attributed some of his Olympic success, I don't think it was all of it, to the Graston technique and his recovery and his rehab. It's been well represented at the 08 Beijing Olympics, as well as the US Open, just to name a couple of important sporting events. So these are some of the conditions we treat with GT, and this doesn't cover all of them for sure. Things like Achilles tendonitis, carpal tunnel syndrome, your typical neck pain or sprains, even more chronic conditions like fibromyalgia or lateral elbow pain, simple muscle strains, things like trigger fingers, shin splints. We've seen some really great outcomes with folks with knee replacements who are developing stiffness after their knee replacement, or some with something like IT band syndrome. So before we perform GT with anyone, we talk a little bit about what some of the side effects might be. And just like any of our other techniques in physical therapy, the number one side effect you may have, but you may not have, is that you might just get sore. And it's similar to any of our other soft tissue techniques or joint mobilizations. You may be a little bit sore afterward. Some people will experience a little bit of bruising. And if you have more fair skin and you're more prone to bruising, then the likelihood that you're going to bruise is a little bit higher. But I can say in the time period that I've been using it, and Becca could probably speak to her own experience, I haven't had anyone come back with a bruise on them after having a session with GT. Chronic conditions actually respond really well, and the theory is that the soft tissue mobilization sort of reinitiates the active inflammation process. So when something is more chronic, you know, we think of sort of, kind of going back, if we think about something like a tendonitis. Tendonitis would mean it's a really acute inflammation. Your body's working really hard to heal it, but you get out of that acute inflammatory phase very quickly. Once you get out of that acute inflammatory phase, the tissue starts to break down. So with the GT or our other soft tissue techniques, we try to reinitiate that acute inflammation process to kind of get the healing process started again. Just like with any of our other techniques, it's something that we don't use all of the time. You may get 2 treatments a week, depending on your frequency of physical therapy treatment. You may be someone who gets it 3 times a week, or maybe even 1 time a week. In the literature, it says most patients have a positive response within 3 to 4 treatments. We're seeing immediate treatment effects. And that's not for everyone, but for the most part, after we perform the technique, we expect an immediate change in their pain or in their range of motion, for example. So these are some of the theories behind why GT works. So it separates and breaks down collagen crosslinks and splays. So those are sort of the areas you can think about when you run over a muscle and it feels kind of bumpy. It stretches the connective tissue and the muscle fibers. It definitely increases skin temperature, just like if you were getting a massage. Facilitates reflex changes in the chronic muscle holding pattern. So it gets the muscle to just relax. It increases the rate and amount of blood flow to and from the area, so that's where you'll get some of those temperature changes. and it increases the cellular activity in the area, and it brings in these cells that'll help facilitate better healing. It also increases the histamine response, so that's where you can get a little bit of redness shortly afterward. Decreases the overall time of the treatment, so I can tell you from my standpoint as a clinician, I can perform GT on someone's entire thigh in about half the time I could do it with my hands. So that leaves us more time for stretching, exercise, balance activities, other functional tasks. So it really kind of opens up the treatment window and makes things more efficient. One of the other nice things about it is we want you to continue to perform your daily activities. We don't really want to change those things. We don't want to take you back away from them. There aren't any reasons that you would have to rest for the rest of the day. It's not a technique that's going to make you that sore that it's going to take you away from your typical activities. So after we perform GT, we're going to go right into the stretching, right into the strengthening, and right into the movement part of our treatment. And it's really important that all of our patients follow up with their home exercise program and they're consistent with that. Otherwise, they're not going to be able to maintain the gains that we made while we were in treatment. There are some conditions that make us think twice before we perform any manual therapy interventions. So this list isn't just something that we think about with performing the Graston technique. So these are some conditions where I'm going to go, is that really what I want to do? Is this really going to benefit the person that much? And can I do that in an area that's safe with their other conditions? It could be cancer, around burn scars, or even after someone has had, for example, a knee replacement. We want to make sure that their scar is well healed before we're poking around the incision anyway. Something like complex regional pain syndrome, rheumatoid arthritis, varicose veins, lymphedema. These are all conditions where we just think a little bit more before we perform any of our techniques, and we determine whether it's really the appropriate thing. There are some times when we would never perform the Graston technique, and for some of these we wouldn't perform any manual therapy interventions. Something like open wounds, you don't really want me to scrape this stainless steel instrument across your open wound, and my next person doesn't really want me to scrape that across your open wound either. Conditions like thrombophlebitis, uncontrolled hypertension is actually something that we think about a lot with all of our manual therapy interventions. If someone has any kind of contagious skin infection, hematomas, osteomyelitis, and unstable fractures. In general, if you come in with a very acute inflammatory process, we're probably not going to be doing GT with you that day. There's a lot of information out there on the Graston technique. If you would like more information on it, certainly talk to us. We have more information available. But the most reliable website is to go right to grastontechnique.com. That will give you the most up-to-date literature, and it actually provides a very long list of medical literature to support the technique, as well as you can actually search for clinicians in your area who perform it. So I think we'll move on. Becca's going to come up and talk about the dry needling.
All right, so let's try. Okay, so dry needling, kind of going along with what Kate was talking about. It's just another way of saving our hands within the clinic. What is it? It's defined as a skilled intervention that uses a thin filiform needle to penetrate the skin, and it's stimulating an underlying trigger point, muscular or connective tissue, for the management of certain conditions. It can be used to treat dysfunction in skeletal muscle, fascia, and connective tissue. And we think it works by diminishing persistent peripheral nociceptive input, reducing and restores impairments in the body structures and function, and overall leads to just improved activity.
Can you say like what that means?
Sure. So nociceptive input is like bad input. So a nerve sending a signal to your brain that is something is wrong in the body.
Nociceptive? Is that what it is?
Restoring impairments in your body would be restoring your motion, restoring your strength, restoring your balance, kind of how you're moving.
First line.
Yeah. Okay. And peripheral is anything that's not in the brain or central nervous system. works on trigger points. So what is a trigger point? A trigger point describes a taut band of muscle. So if you think of that golf ball that might sit in your shoulder when you touch it, you're like, oh man, somebody would just massage this out for me. That would be great. That could be a trigger point. They can be tender to touch and can refer pain to different areas of the body. So you might touch that spot in your shoulder and say, wow, when I push in here, I get a headache, or I feel pain in the back of my eye. That's that referral pattern. Physical therapists like us are using dry needling with the goal of releasing those trigger points and helping relieve the pain. Trigger points can also be thought of as a hyper-irritable spot within that top band of muscle. So it's just getting a lot of nerve input to it that's causing it to be contracted. You can divide them into two types of trigger point. There's an active trigger point and a latent trigger point. So actives would be ones that are spontaneously painful. You push it, it hurts. They are larger generally, and when you look at them under a microscope or actually hook them up to studies, they show a decrease in circulation. There's a decrease in oxygen to that area. Latent trigger points are only painful if they're stimulated, say, with a needle or with like a EMG type study too. So trigger points can cause some myofascial pain. And they can do that because of sustained postures. They can do that because of repeated movements, trauma, or radiculopathy, or pain that's coming from somewhere else. So that guy's posture would probably give him some trigger points in his neck. It's a big, long list of things that trigger points can be caused or causing. We can see them with diagnoses such as joint dysfunction or arthritis, disc pathology, tendinitis, migraines or different types of headaches, carpal tunnel syndrome in the wrist, computer-related disorders. So a lot of our patients who come in with neck pain or shoulder pain that work at a desk all day, we would call that a computer-related disorder. Spinal dysfunction, complex regional pain syndrome, and some others on the list. This is not an all-inclusive of everything. There are many other diagnoses that could be listed. So these referral patterns that trigger points can do. You might have pain that you think is down here, but is actually coming from a trigger point up in a muscle in the hip. Same thing with down in the lower leg. You could have pain down in the bottom of your foot, but it might not actually be coming from something down in your foot. It could be because of the trigger point that's up higher up in the lower leg. So how does dry needling work? It causes a micro lesion or a tiny little irritation to the tissue that will break up shortened tissue, will inhibit this nerve signal that's going from the nervous system up to your brain, normalizes the inflammatory response. So similar to Graston in trying to take things from a chronic condition to a more acute condition that your body then will respond to, and centrally mediating the pain. It just provides an environment that enhances the body's ability to ultimately reduce this pain. Sometimes with these chronic conditions, it's almost like your body has forgotten about it. Sort of still going on, but it's just not 100% better yet. So like Graston, dry needling tries to reactivate that area to remind it that, hey, there's still something going on here that I need to address. Primary research that we have supports that dry needling improves pain, reduces muscle tension, normalizes dysfunction within the muscle, and facilitates ultimately a return to activity. And then just some examples of some pictures of it. So it's not acupuncture. It uses the same type of needles, but the philosophy behind it is different. So dry needling is solely based off of Western neuroanatomy and modern scientific study, focusing on musculoskeletal and the nervous system. Those of us that perform dry needling do not take on traditional acupuncture theories or acupuncture terminology. So we're not doing Chinese medicine. We're not trying to change energy flows within the body. We're specifically targeting a muscle for a purpose of getting it to relax. treatment effects come in a few different forms. So a mechanical treatment effect is a twitch response. Oftentimes when the muscle is done with the needle, you can get this twitch that occurs, and what you're getting is the muscle contracting really quickly and then relaxing. It causes a vascular, inflammatory, and immune response. You can get spontaneous electrical activity to the area, so you're increasing that nerve signal to the area. And it works on your ascending and descending pathway changes, so messages that are going up and down from the brain. In our clinic, dry needling falls consistent with our current work and body of knowledge. We're all trained in anatomy and physiology. It is recognized as being part of our scope of practice by our governing board in the state of New Hampshire, and also by our national organization. It's just another tool that we can use to help us increase our depth of precision. So we're three-dimensional, and sometimes we just can't get to that muscle that may be causing the problem. This gives us the ability to increase our depth into that tissue. And we can use it in conjunction with our exercises and our balance work and stretching to just really round out the treatment. We wouldn't want to do just dry needling and let you walk out of the clinic, because we wouldn't really be fixing what's going on. We need to be changing movement patterns, working on strength, working on range of motion. So here are a couple of resources that talk a little bit more about dry needling. We have copies of these we can make for you. It's a couple articles that the APTA has put out, kind of talking about PT and the role with dry needling. So, for Kate and I, any questions? Yeah.
Are either of these or both covered under medical insurance?
They are. So they're both considered a manual therapy. So it falls under charges that we would do for manual therapy.
Do you need a referral?
So depending on what your insurance is, yes, potentially. It does not have to be specifically for Graston or for dry needling. What we would look at on your first visit in is this something that we think would benefit you in the course of treatment?
Is this something that you would have done once or a few times?
So for dry needling, it could be done once. It could be done multiple times. I think the research has shown, sort of similar to Graston. We're seeing effects in the research 3-4 sessions in, but there's an immediate effect with it. I think typically after about 5 or 6 times of it, I'm starting to back off a little bit. I think with Marcia and Bill, that's probably similar too. But by that point, we're hoping that we're moving more into strengthening and functional activities anyways. Okay. You look like you have something on. It's there. It's there.
So a person comes in, and how do you start through the process of knowing where you go to which person, which modality, whatever?
So coming in on your initial visit, Kate and I do Graston, Marcia, Bill, and I do dry needling, but that doesn't necessarily mean you have to be evaluated by one of us to receive that treatment. We would be looking at things like your movement, your strength, where your pain is, what your impairments are, to figure out what's going on, to give us a better idea of what we need to do to treat you effectively. And through that process, if we're deeming that, hey, maybe Graston would really be beneficial for you to work on this, we can schedule appointments as needed with either Kate or myself if you were seeing somebody else. So kind of the same thing with dry needling. Or pull one of us in a treatment visit here to say, hey, do you have 5 minutes? You could come in and do this. Does that answer?
Yeah. Just walk through and say, treat me.
Here I am. Kind of, yeah. Yeah. If your insurance requires a referral, calling up your doctor to get in to see them so that they could refer you. And that's something that our lovely front desk folk could probably answer for you.
Yeah.